A very good evening, everybody. I, Dr. Komal Chavan, Chairperson, Foxy Medical Disorders in Pregnancy Committee, welcomes you all to this webinar on RPL, recurrent pregnancy loss, isoimmunization in pregnancy. This is the concept of bridging Bharat. And in the era of this COVID lockdown, where we are celebrating Ganesh Chaturthi, and today being the second day with the blessings of Lord Ganesha, let us begin a series of webinar which we are going to start in the last week of August. And today's topic, we have stalwarts with us. We have none other than Chief Guest Dr. Shanta Kumari, President-elect Foxy, Iron Lady of India now, not South India, the whole India, and who is always supportive and kind enough and gracious to be the chief guest and to inaugurate our webinar. And I call upon Dr. Niranjan, the coordinator and the moderator for this webinar, to welcome Madam and to introduce Madam, and then I request Shanta Kumari Madam to address all the viewers with words.
Thank you, Dr. Komal Chavan. It's a pleasure to be here. And we are in South India. We are going to cover today the South India, and we have Kannur, Manipal, and Hyderabad Obstetric Gynec Society, and along with all those members who are the panelists, this CME is inaugurated at the esteemed hands of our President-elect Foxy 2021, none other than the Iron Lady of India. I welcome Dr. Shanta Kumari Madam. Please come. Can I have our slides, please? As you know, she is a consultant at Yashoda Hospital, Hyderabad, and we have nostalgic memories with her when she started her journey in Foxy and IAGE. I remember the first conference which she had held, I think as far as I know, was in Hyderabad for IAG, and then we know in 2011 there was the organizing secretary, Dr. Shanta Kumari, who organized the AICOG of Hyderabad. From that point, there is no stopping, and she has just gone ahead, and she has done wonderful conferences at HICC, Novotel, and of course, most important thing is the violence against women. She is in the FIGO working group, and we have the wonderful program Dhira, which she is running from Hyderabad and guiding the FIGO working group. She has many hats, donned many hats on her cap, and one of them was as a chairperson of the ICOG 2018. We know as a vice president of Foxy and a secretary TCOGS, she has worked very hard and has got many degrees, not to mention about the MRCOG, FRCOG of Honoris Causa UK 2018, FRCP of the Royal College of Physicians of Ireland, and she has got also various prizes. Thank you, madam. Now I request you to please inaugurate this webinar which we are going in south of India with Foxy medical disorder, and I request you to please guide us for a few minutes. Please take the mic and share your thoughts, and we will go ahead with this inauguration.
Good evening. Good evening, everyone. Thank you very much, Niranjan. But let me be honest, I am not the chief guest. I've got my teachers here. They are the most important people here. We have Pratap sir, we have Murli sir, yes. PK Shekharan sir, Paili sir, Sanjeev Reddy. When all of them are there, we are still the students. So it's actually, when Niranjan, when you invited me to be on this panel, I was very thrilled because it was an opportunity to meet everyone virtually, if not physically.
Yes.
So that is the best part, and it's a pleasure to see that all the societies of Kannur, Hyderabad, Manipal, Thrissur, and Calicut societies are actually together in this webinar. I'm sure this is going to be a successful webinar because you've got very good, esteemed faculty, and everyone is actually looking forward for this webinar. I know I have seen the links being forwarded in our Hyderabad society.
Yes, madam.
So this is really a very good webinar. Thank you very much, and all the best to everyone who are there. And a real pleasure to be here. And we have to appreciate the Science Integra also for coordinating this good CME I should call, if whether it's a web CME or a webinar. I think this is what is connecting all of us. Thank you very much and all the best for the great program.
Thank you, madam, for your opening remarks. And now this webinar is open at the gracious hands of Dr. Shanta Kumari, madam. I know आप मुझे बोल रहे हो चुप बैठो, लेकिन नहीं, चुप नहीं बैठ सकते, madam, because I am really charged now, and I have with me, madam, जो आपके टीचर है वो मेरे भी टीचर है. Can I have the next slide? And this is none other than Dr. Pratap Kumar sir. Pratap Kumar sir, I met him in 1996 when I went there to learn IUI and IVF, and that's how I met sir. I was working with his unit at Manipal. Can I have the next slide, please? I want to have the CV of Dr. Pratap Kumar sir. We know that he is the head of the Division of Reproductive Medicine, Kasturba Medical College, and I want to know a great teacher. I used to go at 8 o'clock in the morning, used to do ultrasounds, and then we used to be there till 5 p.m. Twice a week, we used to go to the operation theater, and I know Shanta Kumari has worked in Kasturba Medical College, so she will be in a much better position to tell about him. That's the reason I got sir, and he has accepted this opportunity to be there. They have a wonderful library after the work of being the OPD, and I remember sir used to have a dictaphone, and even small letters and references used to come. Please, he used to make it a particular point that immediately he used to write and talk to them, and a letter used to be drafted immediately by evening, and it used to go there to the general practitioner or the referral doctor. So these are small things I learned in the operation theater, wonderful operation theater of Manipal. Sir used to be there. He took me, hold my hand, and he took me there to assist one of the cases of ovarian tumor. It was a wonderful experience, sir. Sir, I'm talking about 25 years ago when we started and when I had come to you after my MD. Thank you, sir. Your CV is lots, and I remember your international travels and the way you have represented India in the whole world and the whole globe. You were the vice president of Foxy, and thank you so much to being there. Sir, we want your few words and your inspirational guidance to us. Thank you, sir.
Niranjan, before Pratap sir talks, can I just add something? Yes, I think for if any postgraduates or young consultants are here, I have to tell you all, one thing you can learn in your post-graduation is your discipline. That is what we all learned in Manipal, and we have to thank Manipal sir. I'm sure I wouldn't have been what I am today but for Manipal. You know, I can never forget. So Pratap sir is there, Murli sir is there. I just was mentioning, look at sir at any time, any program, the way he is very impeccably dressed and with that sort of discipline. I think all juniors have to learn that, and the way you treat your patients and all that goes a long way, sir. So we hope that many more teachers actually follow you all, and we have better students coming out. Thank you, sir.
A very good evening to all of you. Thank you, Dr. Niranjan, for inviting me and for telling good things about me. And Dr. Shantakumari always are with us, and I'm so glad you remember. And you always mention that in many places. I'm very happy to know that our students remember us for many years. That's a big achievement for a teacher. I think today I'm very happy to be here as one of the guests of honors because a very important program. First of all, RH Isoimmunisation is always a problem. But though its number is less, I think things have become better with the advancement of science. And I'm sure Dr. Sanjay Reddy, who's my good friend, will definitely tell us about the recent advances. And we have a lovely discussion on recurrent pregnancy loss by the team. And I always felt it's never complete because we do not know all about recurrent pregnancy loss. Even we are still, in spite of listening to hundreds of people, we still have the same doubt. And but we are much better than before. But I think we have had several kind of patients. The other day I had about 6 abortions.
Please, sir, unmute your mic. Yes.
Sorry?
Yes, sir.
You can hear.
Yes,
I never thought immunological causes should be really evaluated long back. And I found the anti-nuclear antibodies are strongly positive. Anti-nuclear profile was positive. And we just gave her the medication. And of course, APLA was also positive, and she did brilliantly well throughout the pregnancy and delivered a live child. So I think the things have changed. We have added on immunological rejection factors, which is not proved beyond doubt, but we will definitely go on discussing today. I wish this seminar all the best, and I'm so happy to be with all of you. Thank you so much.
Thank you, sir. Thank you for your kind words. Now, can I have the slide of Dr. P.K. Sekharan, sir? There are, 5 PKs in my life. And Subbu, I'm going to take some 5 minutes more. Please excuse me. One is Dr. P.K. Shah. Another is Dr. P.K. Sekharan. Third is Dr. Pratap Kumar. And the fourth one is my father-in-law, who is P.K. Sankhe. So actually 4 of them, rather than being 5, they are very important persons in my life. And sir has always guided me for last 20 years. Sir, it is honor, and you have blessed us that being here, you are a doyen in the gestational trophoblastic neoplasm. And sir, I want to tell you, what you have taken India to the world is amazing, from a small town of Calicut. And I remember you and I meeting madam when you used to come to Bombay and to AICOGs, the way you used to be affectionate to all of us, all the students. We were just being postgraduate, and then I came to you, and now as an examiner, sir. It's a whole round circle. You were also in the FIGO working group, sir, of GTD in 2015. So many GTD conferences you have organized, and many publications, sir. And I remember you had taken me as a West Zone coordinator for the Norms and Nomenclature Committee, which was formed that time. And sir, your work on maternal mortality surveys used to call me, used to distribute those in the managing committee, and that's how we used to try to get the data of maternal mortality. This I'm talking about 15 years back, sir. I think the younger generation should know a lot of things from you. Thank you for being there, sir.
Thank you, Niranjan. Thank you very much for that kind words. Thank you for organizing such a combined conferences of the most of the southern state societies, the Hyderabad, Kannur, Manipal, Calicut, and Trichy. And I am happy that you are taking up 2 important issues. One is the isoimmunization, which is dealt with a very good faculty, very great friend of mine. And then you are having the panel on recurrent pregnancy loss. How many times you had listened to and read about this thing, but it's not still complete to see that we are not able to complete all these aspects of recurrent pregnancy loss. Dr. Shatakumari, of course, is going to lead us the next year, and she started leading us from this year onwards. Thank you, madam, for being there and going to help us in these hours of crisis of where we are not able to meet, but we are still doing the academics. So thank you, Niranjan. I wish the academic session a great success. Thank you once again.
Thank you, sir. Thank you for those kind words. The idea is that let's not forget the icons, the legends who were there taking India further ahead. We are in 2020, but people and the delegates who are joining should know what has happened in 1990s, what has happened in the last decade. So there we are, our last guest of honor, and he is the highest of all, none other than Dr. V.P. Piley. I am very blessed and graced to have him on this first South Indian webinar. I know, sir, you are very busy. A lot of programs were there today morning. And from tomorrow onwards, there is a big program being coming, organized by you and Ashwath. It's amazing that you have represented India and have given a lot of applause to us, especially in instrumental vaginal delivery, obstetric practice, and the way you talk. It mesmerizes all, and I have witnessed that in Mumbai. Sir, it's an honor that you are here. Thank you so much. You have represented Kerala Obstetric Gynec Society and also been the state coordinator of the confidential review, a very down-to-earth person and a professor. Thank you, sir, for being with us. And please give us your inspirational words. Welcome, sir.
Am I audible now?
Yes, sir. Yes, sir.
Okay. Thank you. Thank you for this opportunity to be a part of this webinar, where you are dealing with 2 important topics in our day-to-day practice. And of course, an eminent faculty, list of faculty here. But all the other VIPs here, Shanda, Pradap, Murli, my own friend Shekaran, and all of you for carrying on with these academic sessions day in and day out. I'm sure that will have its impact on our day-to-day practice. And the topics we are covering today are, of course, relevant, especially the recurrent pregnancy loss. And as Shekaran said, there's no end to the controversies. Probably we'll hear more controversies just to follow after this. But at least some take-home messages will come out of it. New knowledge comes. And I'm glad that you all are arranging such a webinar on relevant topics. I congratulate all of you. And Niranjan, thank you very much for asking me to be a part of this. We wish you all the best. Thank you.
Thank you, sir. Thank you so much for that inspirational words. Now, we start with our CME, and we are going to start with RH Isoimmunization. And I have none other than, the great Padma Shri. There are very few Padma Shris which are there in India. And one of them is our professor, our own gynecologist, head of the Department of the Reproductive Medicine from Chennai. It's an honor for him to be there to deliver this wonderful lecture of RH Isoimmunization in pregnancy. Please watch it. You will enjoy this flow. Sir is a past president of OGSSI and also was a part of the All India Congress of Obstetrician and Gynecologists of Chennai in 2015. And we hear a lot of Tapisar, Isar's programs. And that's it, Dr. Sanjeeva Reddy. I don't want to be there in much between him and you. So please, all of you enjoy. I will come back to you after the lecture with a panel discussion and we will have few questions for sir. Thank you so much. The mic is yours, sir.
Thank you, Niranjan, for a kind introduction. At the outset, I would like to thank the organizers for inviting me to share some of my thoughts today with you all. Today, I am going to speak on management of rhesus negative pregnancy. Rhesus factor is a protein found on the red blood cells of most people. When a person does not have this factor, they are called RH negative. When a RH negative mother is exposed to RH positive red blood cells, she may produce antibodies in her body called isoimmunization or alloimmunization. These antibodies could cross to the fetus across the placenta and form complexes with RH positive fetal red cells. These affected RBC destroyed by the reticuloendothelial system of the fetus. The numerous antigens on the surface of RH positive red cells have been placed into groups. The rhesus antigen constitutes at least 3 very similar transmembrane proteins called C, D, E. Although D is the most important antigen, other RH antigens can provoke antibody formation such as anti-E and anti-C. The non-RH groups such as KEL, MNS, and KIT also have assumed increasing importance since they could produce red blood antibodies as well. Globally, the Basque population of Spain has the highest incidence of RH negativity, that is up to 35%. In others, like whites, if you take, it constitutes around 15 to 16%, Native Americans 10%, African Americans 8%, Black Africans 4%. In Asians, it will be less than 2%. Two common systems for blood group classification is there, ABO system and rhesus system. Under ABO system, we have A, B, AB, O antigens are seen. Rhesus system, capital C, small c, D, E, and E will be there. There is no D antigen, that is, the letter small d represents absence of D antigen. The D antigen is considered to be the most immunogenic. If we take the pathophysiology, if the female partner is negative for this gene, that is, no copies of RHD gene present, and there are two types will be there in the male partner, depending upon he is homozygous or heterozygous. If he is homozygous, he will have 2 copies of RHD gene will be present. If he is heterozygous, he will have only 1 copy of RHD gene will be present. If he is having 2 copies, then all the children born to these parents will be RH positive. If the male partner is heterozygous, then 50% of children will be negative and 50% of children will be positive. The amount of fetal blood necessary to produce RH incompatibly varies, but as little as 0.1 ml of RH positive cells have been documented in some cases to develop RH isoimmunisation. Studies have suggested that up to 30% of people with RH negative blood never develop RH incompatibility even when challenged with large volumes of RH positive blood. This is because of genetic change in the antigens. RH alloimmunization occurs in one of two mechanisms, either after incompatible blood transfusion or after feto-maternal hemorrhage between mother and an incompatible fetus. Feto-maternal hemorrhage may occur during antenatal, that is during pregnancy or during delivery, which notwithstanding, fetal RBCs have been detected in the maternal blood in all three trimesters, first trimester, second trimester, third trimester. The initial maternal response to RH isoimmunization is low levels of immunoglobulin IgM antibodies. As it is having high molecular weight, it cannot cross the placenta. That's why baby won't be affected. Within 6 weeks to 6 months, IgG antibodies are produced. These are able to cross the placenta and destroy fetal RH positive cells. Therefore, firstborn infant with RH positive blood type are not affected. The short period of first exposure of mother to fetal RBCs is insufficient for production of IgG antibodies. This slide shows the amount of blood, feto-maternal hemorrhage that can occur in the first trimester, second trimester, third trimester, and during delivery. So there are some conditions during antenatal periods and also immediately after delivery, will be having more amount of blood feto-maternal hemorrhage can occur. During antepartum period, if you take miscarriage or evacuation of retained platters of conception, ectopic pregnancy, obstetric procedures like amniocentesis, corneal bolus sampling, external cephalic version, fetal blood sampling, in utero blood transfusions, all will lead to excess feto-maternal hemorrhage. At the same time, any abdominal trauma also can predispose for more amount of blood. Intrapartum, if they apply forceps or if you are doing cesarean section, there is delivery of the stillbirths or multiple pregnancies can lead to hydrops fetalis, placental abruption, manual removal of the placenta. All this can encourage more amount of feto-maternal hemorrhage. Postpartum also, sometimes we can give the incompatible blood. In all pregnancies, what is grandmother effect or theory? We will be thinking usually the first pregnancy won't affect at all. It is not true. The grandmother effect or theory, if you see, in all pregnancies, small amounts of maternal blood enter the fetal circulation. Real-time polymerase chain reaction, that of PCR, has been used to identify maternal D positive DNA in peripheral blood from preterm and full-term D negative newborns. Thus, it is possible for a D negative female fetus exposed to maternal D positive red cells to develop sensitization. When such an individual reaches adulthood, she may produce anti-D antibodies even before or early in her first pregnancy. This mechanism is called the grandmother effect or theory because the fetus in the current pregnancy is jeopardized by maternal antibodies that were initially provoked by his or her grandmother's erythrocyte. The sequence of events leads to hemolytic disease of newborn. Maternal IgG enters fetal circulation via placenta. This leads to destruction of fetal red cell occur, leads to fetal anemia. There is heme is formed and converted to bilirubin, leads to fetal hyperbilirubinemia. Both are neurotoxic, but effectively this will be, the fetus won't be affected until the fetus is inside the womb. Extramedullary erythropoiesis is stimulated. Immature erythrocytes are produced. When cell destruction exceeds production, severe anemia occurs. More demand on extramedullary cells to produce more red cells, leading to hepatosplenomegaly. Heart failure eventually results with ascites, edema, and pericardial effusion and leads to erythroblastosis fetalis. In hydrops fetalis occurs when the hematocrit falls below 15%, often leads to fetal death shortly before or after birth. If you take the sex ratio, Male fetus are involved 13 times more than the female fetus. You see the sequence of events and development of erythroblastosis fetalis. A couple where the husband is positive and the mother is negative conceive Rh positive baby. Rh immunization is not a problem at the time of first pregnancy. At the time of delivery and rarely in the antenatal period, Rh positive antigens move into the maternal blood through placenta circulation. These Rh positive antigens stimulate the formation of the Rh antibodies in the maternal circulation. This leads to the subsequent pregnancies with Rh positive baby. These anti-Rh antibodies can reach the fetus via the placenta. These antibodies can destroy the Rh positive RBCs, resulting in development of fetal complications like anemia. So this destruction of fetal red cells resulting in anemia, heart failure and death. Buildup of bilirubin resulting from red cell destruction leads to jaundice and brain damage. What is the Rh sensitization risk? The risk and severity of sensitization response increases with each subsequent pregnancy involving ABO compatible fetus with Rh positive blood. Without prophylaxis, the risk is 16% after 2 deliveries. In that 1.5 to 2% occur during antenatal period, 7% will occur within 6 months after delivery, another 7% manifest early in second pregnancy. Suppose if you give the prophylaxis, anti-D prophylaxis, the risk drops to 0.1% only. This sensitization risk depends on the 3 main factors. One is the volume of transplacental hemorrhage, extent of the maternal immune response. Not all patients will respond in the same way. Concurrent presence of ABO incompatibility. Suppose if there is no ABO incompatibility, there is 16% of patients will develop isoimmunization, whereas there is ABO incompatibility, that is a protective mechanism, the risk drops to less than 2%. Rh incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in future. How to manage these negative pregnant patients? The objective of antenatal management is prevention of Rh elimination in the Rh negative unsensitized women and early detection and treatment of fetal anemia in the sensitized women. This is our objective. Sensitization is determined by the 2 tests, indirect Coombs test, otherwise called as antibody screen test. We'll see the flow chart, how to manage Rh negative pregnant. Suppose mother is negative, father is positive, and the fetus may be positive. That's why we have to check the maternal antibody screen at 28 weeks gestation. If it is negative, then the administration of 300 micrograms of immunoglobulin at 28 weeks. At delivery of the baby, the Rh status of the newborn to be checked. If it is negative, no further treatment is needed. If it is positive, then give another 300 micrograms of anti-D within 72 hours of delivery. Suppose the maternal antibody screen is positive at 28 weeks, then manage as Rh sensitized pregnancy. We'll discuss this one in detail later. This is amniocentesis for estimation of fetal bilirubin. So we can estimate the amount of bilirubin by optical density at 450 nanometers. Further management based on these levels, percutaneous umbilical cord sampling may require or amniotic fluid analysis, ultrasound examination, and we can monitor this patient with ultrasound Doppler. What are the precautions we have to take during delivery in Rh negative pregnancy? Ensure consultation with neonatologist. Don't give oxytocin at delivery of anterior shoulder. If manual removal of placenta required, do so gently. If blood transfusion is indicated, use Rh negative blood only. Early clamping of umbilical cord is indicated. Leave a long length of cord about 15 to 20 centimeters. You may require later the cannulation. What is the postpartum management? Involve the neonatologist, send cord samples for ABO or Rh typing, direct Coombs test, hemoglobin, bilirubin levels, and peripheral smear. If fetus is Rh negative, no further intervention is needed. If fetus is Rh positive, Determine the dose of IgG immunoglobulin to be administered by a 4-step laboratory procedure. What is this 4-step laboratory procedure? Rossetti fetal test, it tells whether there is any feto-maternal hemorrhage is there or not. Next, we have the second step is the acid dilution test or Kleher-Behet test. It will quantify the amount of feto-maternal hemorrhage occurred. Next, third one is the estimation of the feto-maternal hemorrhage. There are various formulas are there. We can use one formula to calculate the amount of feto-maternal hemorrhage. This is important to decide the amount of immunoglobulin to be given within 72 hours of the delivery. This is the Rossetti test. If it is negative, there won't be any RBC clumping. If there is a positive, you can see the clumping of the RBCs. In Kleher-Behet test, the fetal hemoglobin will take this acid thing. It looks very red. So with this, we can calculate the quantification of the amount of fetal maternal hemorrhage. For sensitized women, the management is guided by the following factors: presence or absence of history of previously affected fetus in the pregnancy, maternal antibody titers. Sensitization may be determined by doing an antibody screen using indirect Coombs test. So the indirect Coombs test will be done from the maternal serum, whereas in the direct Coombs test we'll do on the cord blood. Next, this is how to manage a sensitized Rh negative woman. Suppose if no previous cyst affected previous in the previous pregnancy, obtain the ABO and Rh group of husband. If he is negative, no further testing is required. If positive, obtain antibody titer. If antibody titer below critical level by 36th week, continue the pregnancy to term but not allowed to go post-dated. If the antibody titer beyond critical level after 34th week, deliver immediately. If antibody titer beyond critical level before 34th week, further testing we have to use. Like by ultrasound, peak systolic velocity of middle cerebral arteries using Doppler. It will tell us how much fetus is anemic, whether requiring intrauterine transfusion, amniocentesis for analysis and spectrophotometry, or ultrasound examination of the fetus for development of erythroblastosis fetalis and hydrops fetalis, other things. And all these things will help us to take a decision. So percutaneous umbilical cord blood sampling you can do, estimate the hemoglobin level, and at the same time we can see whether the fetus is Rh positive or negative. The determination of the fetal risk is important, as up to 40% of D negative pregnant women carry D negative fetus. So here no need for us to upright, the fetus will be safe. The presence of anti-D antibodies reflects maternal sensitization but does not indicate whether the fetus is D positive. Even suppose if the patient is having the antibodies, if a woman became sensitized in a previous pregnancy, her antibody titer might rise to levels during the current pregnancy, even if the current fetus is D negative. So that means even the second pregnancy, now the fetus is negative also, the antibody titers will be raised. That is called amnestic response. If the father is D positive, in 60% of the cases, he will be heterozygous, that is the D locus. So if it's the heterozygous, the 50% of fetus will be negative, Rh negative. In a D alloimmunized pregnancy in which the father is D positive, it is helpful to determine paternal zygosity for D antigen using DNA based analysis. If you test the father's blood by DNA analysis, you can make out whether he is heterozygous or homozygous. If father is heterozygous, or if paternity is not known, sometimes you may not be knowing who is the father, the woman should be offered assessment of fetal genotype. Traditionally, this was done with amniocentesis and PCR testing, which has a positive predictive value of 100% and negative predictive value of approximately 97%. Non-invasive fetal D genotyping has been performed. Previously we were doing the amniocentesis and testing. Nowadays, no need for us to do the amniocentesis. Here, non-invasive, cell-free DNA from maternal plasma itself, we can assess this problem. The reported sensitivity exceeds 99%, the specificity exceeds 95%, and positive or negative predictive values are also similarly very high. So we can go for this test instead of invasive test. Management of alloimmunized pregnancy is individualized and may consist of maternal antibody titer surveillance, sonographic monitoring of the fetal middle cerebral artery peak systolic velocity, amniotic fluid bilirubin studies, or fetal blood sampling. Depending upon the gestational age at which fetal anemia developed in pre-pregnancies, it is important because anemia tends to occur earlier. Suppose previously it is occurred 30 weeks. This second time it will occur earlier. That's why you should know the time when it developed. Depending upon the middle cerebral artery Doppler velocity, how to manage. It is accurate and non-invasive screening tool for detecting moderate to severe fetal anemia. It is 100% sensitive. There may be 12% false positive rate for anemia. Use has resulted in 80% reduction in invasive testing like immunosensitivity, cardiosensitivity to estimate other things. Not useful. The middle cerebral artery Doppler velocimetry estimation is not useful before 18 weeks of gestation because reticuloendothelial cells are too immature in the fetus to hemolyze the blood. It is not a reliable predictor to estimate the severity of anemia after 35 weeks of gestational age. It is found to be, when compared with the amniocentesis and the photospectrometry, it is found to be similar to or better than amniotic fluid in prediction of anemia. So we can go for that. This slide shows the fetus with severe anemia and without severe anemia, the graphic description of the MCA. See here, the systolic is very less. If the fetus is affected, as I mentioned, the systolic peak velocity is very high. How to manage depending upon the MCA results? Suppose the fetus is unaffected or mildly affected, the values will be normal. The Doppler is repeated monthly once, that is enough. Deliver at or near term after lung maturity. The intrauterine fetal death risk is very low. Suppose if it is moderately affected, the MCA changes will be around 1.5 multiples of median. So here we will be repeating this Doppler studies 1 to 2 weeks once. Deliver after lung maturity, or you can use the enhancement of lung maturity may be necessary in this patient. Suppose if the severely affected fetus, the MCA shows the MOM is more than 1.55 or has frank evidence of fetal hydropsis by ultrasound, fetus needs help to attain lung maturity here before delivery, and there is very high risk of intrauterine fetal death. So we have to decide whether to go for intrauterine transfusion or delivery. So this is the how to do amniocentesis and blood sampling. Here, if you go for the spectrophotometry, the other things are not available. There are two charts are available, Lilly's zones and Queenan zones. In this, Queenan is better than Lilly's zones. So intrauterine blood transfusion, when you will give, it is recommended treatment for severe anemia in utero, typically carried out if the, I showed you like by ultrasound and the MCQ, if it is more than 1.55. Typically carried out between 18 and 35 weeks of gestational age, may be given intraperitoneal or intravascular. Previously, we were giving intraperitoneal. Now, most of the time, they will give intravascular, umbilical vein directly. RH-D negative packed cells with HCT of at least 80% is used. The amount of blood transfusion ML is calculated by pharma, that is gestational age minus 20 into multiplied by 10. Suppose here, if the gestational age is more than 20 weeks, this is showing how to give the intrauterine blood transfusion. How in a sensitized RH negative patient, how to manage postpartum neonate after delivery. Baby should be admitted into the neonatal intensive care unit. An urgent exchange blood transfusion is indicated in moderate to severely affected neonates. If it is mild affection, phototherapy itself is enough. Then we'll discuss about the antenatal prophylaxis. Sometimes during antenatal periods and other procedures also it can happen. Suppose if it is abortion or evacuation are doing, there is a 5% chance of sensitization. Here, if you give 50 micrograms of anti-D itself is enough. If there is an invasive fetal procedure done, this is 11% chance of sensitization. Here we have to give 300 micrograms is recommended. If there is an antepartum hemorrhage, 300 micrograms stat should be given. Suppose if you are doing external cephalic version, there is up to 6% chance of sensitization. Here also we have to give the 300 micrograms of anti-D. At the time of delivery, anti-D prophylaxis, the normal amount of fetal blood that enters the maternal circulation, usually it will be less than 0.5 ml. The dose of RHG antiglobulin is 300 micrograms will neutralize nearly 30 ml of whole fetal blood or 15 ml of RBC, fetal RBCs. So if you give 300 micrograms is enough. Management, suppose sometimes I told you like that there is cesarean section is there, and sometimes there is some manipulation, other things where if you expect there is more amount of blood, then you have to go for the estimate the amount of fetal maternal hemorrhage by 4-step lab test. Why we have to do here is depending upon the blood like hemorrhage, we can calculate the dose of IgG. So here 20 micrograms of anti-D required for 1 ml of fetal blood, fetal RBCs. This is the fetus. What are the take-home messages? Points. Every woman of childbearing age should have her ABO and RH types done at first contact. Obtain the ABO RH types for husband of woman found to be, if he is lady is negative, check the husband blood group. Ensure ICT at 28 weeks of pregnancy, even in primaries, with appropriate prophylaxis if it is negative. A single postpartum dose may be inadequate in case of severe fetal-maternal hemorrhage, there where high risk for more amount of thing. What is the problems in our setting? High cost of the immunoglobulin, not all people can offer. Lack of resources to adequately investigate and monitor fetus in utero. So there won't be all the facilities available to do this thing. Low turnout for antenatal clinics, so we may miss many cases. Poor documentation of pre-sensitizing events. Some are yet to fully grasp the importance, like PHCs, some other places when the patient delivers, we may not get all the, and also patients also will lose their notes, so we may not get the things. What is the recommendation? Advocacy for partnership by government and NGOs to help to subsidize the cost of the immunoglobulin. Special insurance cover for RH negative women to ensure ease of procurement when needed. Involvement of clergy as part of premarital counselors in those patients with RH negative patients. Creation of special fora or groups for RH negative people where potential RH negative spouses can be met. In conclusion, rhesus early immunization is a real problem and real efforts need to be made to mitigate its impact. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of the newborn remain. Great advancements have been made in the detection and management of this condition, and many of our RH negative women can now have a happy obstetric career because of anti-D prophylaxis. Thank you.
Sir, wonderful lecture. It was a great presentation you gave and a lot of insight. I agree with you. Government and Foxy will have to do something regarding the RH isoimmunization to be freely conducted, including the anti-Ds to be given freely in the antenatal period and postnatal period. And also we require a lot of investigations to be done. So there are a few questions which are there. I will just ask one or two of them, and then we will proceed with the panel discussion, if you permit, sir.
Thank you, Niranjan. No problem. You're the boss.
Yeah. Dr. Uma Maheshwari has written how to proceed in the Coombs test positive mother at 20 weeks, sir.
That depends upon the level.
How to proceed in the Coombs test positive mother at 20 weeks?
That's what, like Coombs positive, that depends upon the, like this patient we have to treat as.
Sir, your voice, sir.
We have to, depending upon the antibody levels.
Yes, sir. Yes, sir.
So like that we have to monitor. So if it is more than 1 in 32, it is significant. Depending on that, then I told you like that we can go for the middle cerebral artery estimation. That is what we are doing now. With that,
Yes,
we can
sir.
go for. Depending on that, we can manage.
Yes.
I showed the flow chart how to go about.
Yes, sir. I know, sir. But there are few of them who have joined later, and there are a lot of questions, sir. And very informative talk by Dr. Sanjeeva Reddy, sir. He has given his valuable time to us today, and we will come back to you, sir, very soon. I request you to be there for some time, and I will get back to you. Thank you so much. We will catch up with you soon. Now, I request for my panelists to be ready. The whole India is watching you, and it's
Thank you,
amazing.
Niranjan.
Yes, sir. Thank you so much. And I request you to please show their biodata, and it is not in a particular order because all of you are the greatest torchbearer of Foxy and doing great work in this COVID pandemic time. And I will come to Dr. Muralidhar Pai. How can I forget him? When I joined and I residency, he was a great teacher. I had heard about him. But actually, when I visited Manipal to Dr. Pratap Kumar, there I saw young man being there as an associate professor, and along with them, there was Dr. Rajesh Bhakta and there was Sia Sharma. Right, sir? If I'm not mistaken. And he had also Krishnendu Gupta with him. So that's how I know, sir, for last 25 years. We all know he is presently the head of the department of Manipal Obstetric and Gynac department, a wonderful person, a great singer, and he has got 8-time Best Teacher awards from KMC Manipal. And he is also the author of Holland and Views, Manual of Obstetrics, the 4th edition, National Chairman of Foxy Public Awareness Committee in 2004, has got many national awards, 172 publications, 434 presentations as a guest lecturer, and many awards to his credit, 34 years of teaching experience, and he has got 30 years of experience as MBBS. So welcome, sir. Great pleasure of you to be joining us. Thank you, sir. Next, please. Next slide, please. I have with me Dr. Shaijush, the young and dynamic president of the Noor Society. You will find him most of the time in most of the webinars and most of the WhatsApp groups trying to campaign, and a very energetic in the midlife crisis, in the midlife committee of the Foxy. Well, this is his biodata. You can see he's a wonderful person, is having a lot of efforts in robotic surgical system, and we are going to ask him some questions about endoscopy. He's a chairperson of research committee, Kerala Federation of Obstetrician and Gynecologists, and fertility specialist. He has got ARMC, IVF Fertility Center, Kannur, and many awards. Welcome, Dr. Shaijush, the man with the long mustache going down towards his chin, the one and only Dr. Shaijush.
Thank you, sir. Thank you.
Next, and Dr. Subhas Malya, the young endoscopist from Kerala. What can I say about him? I meet him all the time in conferences, very down to earth, very soft spoken. He has got a great responsibility, and I wish him all the best.
Thank you, sir.
For the endoscopy committee campaign for the Foxy. He has taken degrees from Germany, at DNB, DGO, MNMS, and he is in the managing committee as a member of the IAG, South Zone Coordinator of Foxy 2020, member of the Endoscopic Committee 2018-21. And how can we forget that wonderful conference which he did in Kerala? I remember that GTD conference in 2019, and is currently the president of the Rotary Club of Calicut Midtown. I was going to go and meet all of you in Calicut, Kochi, and Kerala, but somehow because of Corona times, we could not make it. So welcome, and
Thank
we
you,
will
sir.
have
Thank you very much,
a
sir.
good time. And I want to tell you, we've got more than 1,000 viewers now today watching all of you. And we have got Dr. Chinmaya Ratha. She's a very big consultant in fetal medicine and an approved trainer in India from the UK Foundation, RCOG UK moderator, a long list of awards, and she is also at the helm of affairs as the secretary of OGSH in Hyderabad 1618, treasurer 1921, and I'm sure you will be soon be the president of the Hyderabad Society. Welcome, madam. You are a great person. Thank you for being there. The beautiful Chinmay received
Thank
Wonder
you.
Foxian Award too. How can I forget that? In November.
Thank you so much.
Yes, yes, yes. Thank you. Now, we have the young dynamic guy practicing in Kerala. I don't know, he's from Kolkata, but he has come to Kerala, or he was born in Kerala. We'll hear it from him.
Yes, sir. I'm actually from Tripura, but somehow I'm settled in Kerala now.
Oh, ki hole, ekeno kothay.
Married to Punjaban also, sir.
Oh, so that's a total amalgamation
National
of
integration.
National integration, sir.
Yes, so this is what we call bridging Bharat.
Yes, sir. Yes, actual. This is the real example, sir.
So, wonderful CV. I've seen you. You have been trained in Pune and 18 months fellowship in gynecologic endoscopy. And you have been operating as a young faculty in IIG. I'm very proud of you, Sandeep. We
Thank you,
shared a
sir.
room
Thank you so
together.
much for involving me.
Yes, we shared a room together when we had come for an endoscopy conference at none other than Hyderabad. And we meet again today. And it was so pleasure. And we were there together. And it was a wonderful conference.
Yes,
I'm sure Shanta Kumari is there to listen. And then we have Kiran Mai Devinini. Kiran Mai means Mai. It's mother, mother of love. She's the candidate for the chairperson of MTP committee, Foxy, associate professor at the Usmania Medical College, currently the vice president of OGSH, scientific convener of AICOG 2011. And she has got a lot of prizes, coordinator for Dira. I can say Shanta Kumari is totally for her, and we can see all the achievements which she has done. Welcome, madam, and we are going to discuss from the professor. So, with this, I would like to go ahead and stop the sharing of the screen. Today, we will talk about Ganpati. You can see the Lord Ganesha in my house, the earthly abode, in Mumbapuri, Andheri Pashchim, Shukla Pakshe. Well, I just did yesterday the Prati Pran Stapna, and we had the Aartis today. We are given Naivadya. Naivadya is the sweets which we make, and Modak. And I find it very nice that on such an auspicious day of Ganesh Chaturthi, we all are coming together. And today in Mumbai, we spent 1.5 days. So thank you so much for all of you. And I would like to share my slides here without wasting much of your time. I have already introduced all of you. I hope you can see the slides. Please acknowledge.
Yes, sir.
Thank you.
Yes, sir. We can see.
So T.G. Thomas, I really recall nothing which in times past has caused me more anxiety and doubt, or in regards to which I have found it more difficult to get any satisfactory answers, rules from books than the treatment of abortion. And this was more than a century. So we all know we are going to discuss about RPL, but you find that when we have such patients coming, you can see the cartoon, the doctor is stressed out, but no, we are not. We are gynecologists, we are Foxy members. Why did it happen, doctor? Can you explain me? Will it happen again? How it can be avoided? Could have been avoided. So we are here to answer your questions. And mind you, users, when you listen to this panel, I'm sure your all processes of thoughts, dilemmas will be simplified and demystified. I don't want to go to that much of a theory, but we know what is RPL. It's more of a chromosomal abnormality to begin with in the normal population, which constitutes 50%. Well, any abortion which is more than 3 or 4 times and it occurs before 20 weeks, well, it is known as recurrent pregnancy loss. Incidence is 1 in 300. Primary refers to the first time when an abortion has occurred, and the secondary when it has got repetitive losses following a successful pregnancy. And you can see the beautiful chart here. We are going to go through all of these problems one by one and try to finish within 1 hour's time. I hope so. And we will try to give justice. Please, if you feel you want to put your opinion or some comments, please raise your hand and I will give you that opportunity. These are all the proposed etiologies. We will go one by one. So I come to Dr. Chinmay Ratha. Madam, you can read the slides. You have been already forwarded the slides. Be brief and then we'll go to the management. The mic is yours. Thank you.
Thank you, sir. So this first case is a 24-year-old lady who's married for 5 years now. The first time she had a vesicular mole dilated and evacuated. Second was a missed abortion 7 weeks. Third was again missed abortion 6 weeks, and then 6 weeks of blighted ovum. So I think she's had 4 pregnancy losses. She is a case of recurrent pregnancy loss. So
Yes,
what would you like to ask me?
So, madam, here is the profile. You can see the hormonal profile is normal, APLA is negative, and this is how the report has come. You can just go ahead. You're a best and the number 1 in the country right now.
Thank you. So here what we see is a karyotype report. This is a peripheral blood karyotyping of both the partners. While the husband has a normal chromosomal pattern of 46XY, the wife has 46XX, but there is a translocation between chromosomes 11 and 22. And as it says here, there is a reciprocal translocation, reciprocal balanced translocation involving 11 and 22. Breakage and reunion has occurred at the bands which are specified here in the Q arms of those thing, and the fish shows balanced translocation between 11 and 22 with specifying the break points of those things. So basically every chromosome has a P arm and a Q arm. P is the short arm, Q is the long arm. And here there is a translocation. That means material from chromosome 11 has gone and connected in 22, from 22 has gone and collected in 11. So this lady herself is normal, but she has a translocation.
Okay. So good. So nicely explained. These are the few slides you can go through. I'm sure there are different percentage wise. You can please go ahead, read. It's your.
Yeah. So basically, there can be a lot of chromosomal problems, and we know that most of the miscarriages that occur in the first trimester are because of inherent chromosome abnormalities in the conceptors. And here we can see in terms of percentages, there could be a monosomy in about 13% cases, trisomy most of the times, 66% cases, triploidies in about 13-14 cases, and structural malformations like the ones which we just discussed, where it's 5.5%. So this lady herself has a translocation, and therefore when she forms a gamete, she may form a normal component of the gamete, or she may form a abnormal or a unbalanced translocation in the gamete, and therefore that unbalanced translocation fetus will not be viable and will end up having a miscarriage, just the way she had it here. So there is a chance of repeat aneuploidy if there is an inherent chromosome abnormality confirmed in either of the partners in a couple who have recurrent pregnancy loss. So that's what we will counsel this patient, that because they are carrying a balanced translocation in the lady, there is a possibility of every time having a unbalanced set of chromosomes in the conceptors, and they could therefore have a repeat of the pregnancy loss.
So, madam, what is about genetic counseling after the marriage? You recommend usually to all such couples? Of course, now is it a trend which is happening in India? Murli, sir, I'm going to come back to you soon, Dr. Murli.
So, sir, what happens?
I'm going to come to you soon. Please.
With every pregnancy, the commonest cause of early pregnancy loss is a chromosomal abnormality. So with just one pregnancy loss, it may not be justified to do all the tests. But in a case of recurrent pregnancy loss, there is a role of doing testing for genetic and chromosomal abnormalities. So there is a role of parental karyotype, because about 3 to 5% of these couples may be carrying some chromosomal abnormalities, like we saw in this case where there was an unbalanced translocation, and otherwise they could be carrying some reciprocal or Robertsonian translocations. Now there is a little difference between them. Reciprocal is the one which we saw there, where reciprocation from 11 to 22 the material was reciprocating. From 11 it went to 22, from 22 it went to 11. So that was like that. In Robertsonian there is a difference, because it happens at the level of the centromere, and it's like two non-homologous chromosomes stick to each other. So that 14, 21, 21, 21, we read during our PG entrance exams a lot of that. Robertsonian translocations are bigger issues, and they can lead to a 45 set in a parent, which may still be normal because they have all the genetic material, but two chromosomes are stuck to each other.
Thank you, Dr. Chinmay. Thank you so much. Dr. Murlidhar, I want your comments here. This is very important. And I know that you and Dr. Lavanya Rai have been doing a lot of work. Because when I had come to Manipal, Dr. Lavanya Rai showed me the whole museum of fetal pathologies. Dr. Pratap Kumar said, Niranjan, you have to go and sit there. And I, as an obedient student, just sat there. And for 1 hour, she showed me all the slides. I was aghast, the collection which your madam has. Sir, please go ahead, sir.
Yeah. So thank you very much. I've never seen a moderator like you, who is almost like a MC of a great grand show. Do you agree, Shaijas?
No, Baba. I'm like you. Anybody like you.
Yeah. Anyway, so coming back to the subject, as Dr. Chinmay has beautifully explained.
Wonderful.
The chromosomal problems are mainly of two types. One is the numerical problems. Other one is the structural problems. Like this particular patient seems to have had both, because first one was a triploid. It's like a polyploidy. She had a vesicular mole sort of a thing, and the numbers were probably just increased there. The second time, third time, fourth time, and it has shown that there are structural problems. And the structural problem is simply nothing but the breaking of the chromosomes. And after breaking, what happens is the issue. So after breaking, either the chromosomes can just change their positions, or they can get translocated. That's called translocation. Or after breaking, they can simply get deleted. So that is deletion. Or after breaking, they can just invert, like palti, 180-degree ulta they can become. So these are the three main problems that they have. So now, that is okay. But what is not okay is whether the genetic material is lost or not is the issue, right? So that is what is meant by balanced or unbalanced. You do whatever circus you want. You go from here and go to another person, another place, and stick there. You stand straight, or you go inverted, or do whatever you want circus. But as long as you're balanced, there's not going to be a problem. If it is unbalanced, then there will be a problem, especially in the females. So it can go up to, theoretically, it is always, we say 25%. But practically, it is up to 15% there can be losses. Whereas in men, somehow, it is less than 0.2%. That's why Dr. Chinmay said, because the problem is here in this particular patient is with the female. So she has got more chance of having same problem every time. So that's what I want to add. And that's exactly why now the solution of that could be, probably she has to go for either an egg donation, or maybe she has to go for, maybe IVF with donor eggs and things like that.
Okay. Chinmay madam, this wonderful slide is there. Please explain us. Can you just highlight this and tell us what are those red arrows?
Absolutely. I think you've shown it very well here, sir. When we talked about translocation, like Muralidhar sir just said, it's like a circus only, isn't it? So a portion of the chromosome jumps from its original location to an abnormal location. But whatever goes from, sometimes you can understand it in terms of alphabets, like you have the series of alphabets. So suppose the triangle from the A goes and sticks to somewhere in T. So that is a translocation, but overall the parts are maintained. So it is a balanced translocation. So here we see a balanced translocation from chromosome 2 to here, which is, I think, chromosome number 17. So this is a balanced translocation. And if the gametes are formed from either both the translocated parts or the normal parts, then the fetus will be okay. But if it has one of the translocated parts and one of the normal parts, then the fetus will be unbalanced and will not be viable. So that is a reciprocal translocation. Whereas in Robertsonian, if you see here between 13 and 14, which are usually acrocentric chromosomes, you see from the level of the centromere, the one chromosome from here has actually got stuck there with the 13. So if the gamete will contain this content and nothing from the 14, it will probably be the same as the parent. Whereas if it contains this from 13 and this from the parent, it will again be a trisomy of that particular 14 or something, and that will be bad. So the mother or the father, whoever has this, has overall 45 chromosomes, but it is still balanced because there is nothing on the 14 and there is something extra on the 13. So this is typical of Robertsonian translocation, whereas this is a reciprocal translocation, 46 chromosomes, 45 chromosomes.
Amazing. I got two wonderful professors here who are consultants in themselves. And the way they have explained it, you know what is the count of users, delegates? 1500. Approximately members are live and seeing you all. And it's all because of Lord Ganesha. You can see Lord Ganesha, who is in the earthly abode of Dr. Niranjan Chavan, blessing all of us, the Foxians. We are going to have Corona disappear very soon, and we are going to virtually meet, all of us going to physically meet. And the way you have explained, I'm amazed. And there are so many members who are being there. And this is what Madam has said, and Murlidhar sir has said very nicely about all the translocation which has occurred. Dr. Murlidhar Pai, non-disjunction, can you please explain this part?
Yes. This is exactly what I meant by non-disjunction is when, you know, an entire set goes. See, in the structural changes, what happens, some chromosomes are broken and they go here and there. Whereas here, what happens in non-disjunction, one entire set, for example, 23, one entire set goes exactly some other place. Or there can be just one or two may just play a game. So, for example, there can be a 69 XXY. That means one entire set has gone somewhere else in non-disjunction. So that will be polyploidy. Whereas one chromosome got missed, like 45XO, it will become Turner syndrome. So this kind of non-disjunction at the time of meiosis can happen. And then there can be mosaics also. That means one cell line can go into 46XX, but another cell line in the same person can be 45XO. So non-disjunction is again a numerical problem where there can be extra chromosomes or there can be less chromosomes.
Chinmay madam, your take on this, and then we move ahead, please.
Absolutely. I think as sir explained, when we form gametes, it's a reduction division. So a person who has 46 chromosomes makes gametes of 23 chromosomes each. And if the separation does not occur at the time of meiosis, if that separation of the chromatids does not occur, like sir explained, there may not be equal amount of 23 chromosomes. It may be 22, 24. And therefore, the 22 will form a monosomy and the 24 will form a trisomy. So non-disjunction, and it increases with the maternal age. The chances of this kind of problems increases with the maternal age.
Okay, so nice. And can you talk about deletions, madam?
I think again, sir explained that very nice. That circus analogy is excellent. So at the time of cell division, let us imagine that all the chromosomes are undergoing a lot of activity. And there is always a disciplined way of doing things. And there is always a time when people don't do things normally, either because the environment is wrong or because they themselves are programmed in a different
like corona
manner.
epidemic, like corona
It's exactly
epidemic.
like the mob psychology, you know. If you're going in a line, you doing a march past like the army, you'll reach your destination exactly at a fixed time. But if everybody has a different psychology, so they run in the marketplace like that, or there is a mob alert and everybody starts either scattered, that is when the chromosomes also break in an unusual fashion. So if they break in an unusual fashion, you may have loss of certain segments of the chromosomes. Now nature is very careful. Nature makes the chromosomes in such a way that there are exons and introns. There are areas which do not actually need to be present all the time. So if you lose a bit of that deletion, it is not pathological. But if you lose a part of a chromosome which encodes for important genes, then that becomes a pathological. Like you've given an example, the Cry-Duchat syndrome. So that's 5p deletion there. Sir wants to say something.
Yes, sir, please.
Yeah, that's what she said. Another beautiful example in our setup is that, he may be a perfect XY, but if there's a deletion of SRY gene, SRY gene is more important than the Y chromosome for us. So this SRY gene is situated in the short arm of the Y chromosome. Just because you have XY, you need not be male always. So if the gene, just a small portion is deleted from that SRY gene, then there is no formation of testis. If testis is not formed, that anti-Mullerian hormone is not there. Then there is no development of the uterus. And there is no testosterone, there is no conversion of the external genitalia. So it will become like a XY female.
So the chromosome may be there, but that critical area, if it is
just
deleted,
one area, SRY gene area is deleted.
It will not function.
Yes. Okay, great. Amazing. All professors being there. And I'll tell you, there are many postgraduates who have joined and they are seeing you. So it's very important to have a proper counseling. And that's what we recommend for our patients. Genetic counseling after marriages, that's what is important, especially when patients have history of recurrent miscarriages and they have peripheral blood karyotyping being performed, and those karyotype reports shows abnormality, and that is a very prompt referral to a geneticist. And thank you both of you to be doing a wonderful justice. Dr. Murlidhar Pai, we go to the next patient.
Sure.
And you can read this. She's a 28 years old. You can go ahead, sir, please.
1 minute. Okay. Yeah.
Yes, sir. Please go ahead.
Right on. So case 2 is a 28-year-old Mrs. XYZ and married for 6 years. Gravid of 4, para 1, leaving 0 unfortunately, and abortions 3. Okay. It should have been 2, I think. Anyway, obstetric history, preterm birth at 7 months of gestation with an abruption. And I think subsequently she had 2 missed abortions, one at 6 weeks, other one is at 8 weeks. So what's your question, boss?
Sir, this is all normal thing, absolutely fine. These are the routine investigations we do. And you study the report.
May I ask you, why do you do torch?
Yes, it has
In
been
this
mentioned.
era.
She had come with all these reports, sir. I have not done anything.
Okay, that's all right.
She has already got these previous reports.
Through this, what I want to tell.
Sir, when a patient has got multiple abortions, they become like doctors.
I know.
They only go and search the internet.
No, but thank you for putting this slide so that I can tell everybody that torch is not to be torched at all.
Yes.
We don't want to do torch infections. The simple reason, let me explain.
Yes, sir.
Because in a case of recurrent abortion, see, a stray abortion, if there's a single abortion, yes, infection, any infection which gives rise to high temperature can give rise to abortion. But there is no infection that can stay for such a long time to cause repeated abortions. If you do torch, anybody will have IgG, but that doesn't mean much. So even RCOG does not recommend doing torch investigations. However, RCOG says torch may be needed in a case of FGR. So they don't do it in case of RPL, but maybe FGR. So
yes, sir. I think we have lost the connection.
But like he was saying, torch can be done in cases where there are fetal findings like fetal ascites and FGR.
Yeah.
Yes, sir. Please carry on.
Yeah.
Yes, sir. Please.
Can you hear?
Yes, sir.
Yeah. Yeah. Can you hear me?
Yes,
Yes,
sir,
sir,
we
yes,
can
yes,
hear,
sir.
sir. ACL
So,
is high.
yeah, okay. So
IgG, IgM is very high. LA is high.
yeah, yeah. So how high? Actually, we would like to see whether it is 99 percentile and more. So that is very important according to the recent Sapporo criteria. That is 99 percentile. It should be high, both LA also as well as ACL. What are the infections causing recurrent pregnancy loss? There's no infection as such that can cause. Does APLA cause early pregnancy loss? Yes. So usually we say it's the chromosome. If there is an early pregnancy loss, less than 6 weeks, 8 weeks, usually it is chromosomal problem. APLA usually happens little later. That is, it will affect later because of its mainly thrombogenic effect. But recent thinking is that in addition to thrombogenic effect, APLA can also hamper the implantation. It can also hamper the invasion of the trophoblast, and thus in totality it can have abortion in many different ways. Probably in this particular patient there is a mixed or multifactorial reason. There may be a chromosomal factor as well, plus a very obvious APLA is already there. Plus, if you see, there was an abruption and preterm labor, which is also a part of APLA, clinical finding in APLA, where the pregnancy has gone actually beyond 20 weeks, but she had a abruption and preterm labor.
What do you think about the coagulation factor defects, sir?
Yes, there are many coagulation factors that are affecting the recurrent pregnancy loss. But the thing is, we do not look for or we do not investigate for each and every coagulation factor as a routine, because it is still today, it is at the experimental level only. Because even if you detect, ultimately the treatment is giving immunoglobulins for these factors. So that's why we do not, as a routine, look for coagulation factors, though coagulation factors play a major role in RPL. What about tuberculosis? I think genital tuberculosis would rather cause infertility rather than RPL.
Of course, we have already discussed about talks.
Can I just add a point, Niranjan sir?
Yes, please raise your hand and say so that I can.
Sure.
Yeah.
I'm Dr. Shaijas. Yeah. Just to add on to whatever Muralidhar sir so clearly explained, he was very specifically mentioning about the high titers that are required before you come to a diagnosis of APLA, because primarily this low to medium titers very commonly can happen because of a viral illness, and within a short duration of time it can get back to normal. And that is why we are talking about a repeat testing, which could be done either around 6 to 8 weeks later, or as evidence would say, almost 12 weeks later, and documented one more time before you come to a consensus of diagnosis of APLA. Thank you, sir.
Okay. You can see SLE. Sir, something about SLE.
Yeah, okay. See, as far as the autoimmune, autoimmune, there are two immunological factors that affect the pregnancy. As far as autoimmune is concerned, the most important and most popular one is actually APS only. Because in APS, pregnancy loss is the diagnostic factor. Whereas in others like ANA, anti-nuclear antibodies, pregnancy loss may happen, but pregnancy loss is not the diagnostic feature of ANA. So that's where is the difference. That's exactly why there has been a lot of controversy whether to actually go by ANA testing as a routine. Recently, that is August 2020, a meta-analysis of 21 papers, they said that, yes, ANA titers, again, if it is 1:160, only then it has got some value. Otherwise, like Shaijas said, you do ANA testing, even in me, there it may be positive. But anything less than 1:160 is of not really significant. Now, having said that, even if a very good association has been found between ANA and recurrent pregnancy loss, when you come to treating it, the results have not been very good. Whether you treat it with IVIG or whether you treat it with HCQ, we are actually treating now with HCQ whenever ANA is positive. Here and there we get a success, but that HCQ study is still going on. So I think I would like to wait till the HCQ study comes up. I hope it will not be like a HCQ in COVID. So anyway, till the report comes, I would rather rely more on ACL, that is anti-phospholipid antibodies, and rather on ANAs. But if a patient has got a lot of problems, and if you have reason to suspect SLE and other things in her, ANA is worthwhile doing it, and you can treat it without waiting for the final report to come.
Sir, I have one case to share with your permission, Dr. Chavan, sir. Hello? Yeah,
Yes.
Kiran here. Yes. So we had one case which presented as recurrent pregnancy loss with, I think, 4 losses. And she simultaneously had this dimorphic anemia, which was recurrent in every pregnancy, along with thrombocytopenia. So we had all the battery of tests. We referred her to Nizam's Institute also. There they had worked up. And initially it was a B12 and a folic acid deficiency, which was thought to be the cause of anemia. With replacement of B12 and folic acid, she drastically improved her hemoglobin levels to around 9 or 10. But the thrombocytopenia continued. So again, we had sent her. There were no other signs and symptoms except this pregnancy loss. Then they had further done the ANA, as you have said. The ANA had come high positive and they have put her on Visalone and HCQ. And anyway, the pregnancy was continuing. It was not with HCQ or Visalone, but the thrombocytopenia, part of it improved with HCQ and Visalone, and she had an uneventful full-term live pregnancy. Sir.
Yeah, that's a nice anecdotal
Yes,
case. Anyway, now coming to treatment, there is absolutely no doubt with regards to aspirin and low molecular weight heparin. Everybody knows that. I don't have to talk about it. As far as anti-paternal cell antibodies, better not to give at all. We gave it 25 years ago, and luckily we didn't burn our fingers, but some people have burned their fingers. So it is not to be given. It does more harm than good. IVIG, yes, if you are very rich and can afford 60,000 worth injections every week till 10 weeks, and thereafter alternate weeks, go ahead with it. It does help. It does help.
So these are the drugs which have been mentioned, and that is what you can give the dosage.
I have a little bit concern about prednisolone anyway, because though it helps, it sounds like a immunomodulator, but better not to give.
Okay.
Better not to give.
Any any doctors would like to have their comments on this, and or we will go ahead, and surely the role of IVIG has been explained by sir. Immunotherapy is there. And there is a passive with immunoglobulins, which is related to the NK cells, down-regulated by the IVIG. Down-regulation is also associated with a very good outcome.
IVIG, could it be given or not?
It can be given.
Right, sir?
If you can afford, it can be given. But usually, it is not affordable that easily. It is usually if you have got a big study going on, PhD going on, somebody is sponsoring that, then only you can.
So the ASHRAE 2018 guidelines, do they contradict this IVIG and all the role generally? I mean, in general, they have told that there's not much role in IVIG.
So that's fine, madam. That's your role. I will go to, thank you, madam. We want such type of, comments, and we want the latest study to be given. And I'm sure Dr. Saijush will speak. And after that, Dr. Sandeep Dattaroy. Unmute, please. Unmute.
My only point was regarding prednisolone. Though we say that there is not enough evidence supporting prednisolone. I know every obstetrician whom you talk to has an experience of having a recurrent pregnancy loss even after giving heparin plus aspirin combination, and having added on prednisolone in the next pregnancy, and probably luckily ending up in a successful vaginal birth. I think I get to hear a lot of this, though we do not have sufficient evidence. Just wanted to add that point.
Okay,
thank you,
Sandeep. Thank you, Sandeep.
Yes, yeah, sir. Regarding that IVIG, there have been a lot of studies with controversial results. Like some say that it is active, some say it helps, some say it doesn't help. And there is a paucity of criteria which cases you can definitely give IVIG and which cases you cannot give. So I think as of now we don't have any definite criteria where you can give it, how much you can give it, and what is the actual outcome. So I feel it is still like we are in an experimental stage. We have to come out with some proper guidelines or some data, which is still lacking. So, and it is also very expensive, and You don't
I
find any
think we have
cause.
understood the point. Dr. Murlidhar Pai has already summarized it.
Yes,
And,
yes.
and Dr. Murli, sir, this is regarding the coagulation factor defects. And these are the methods of testing which we can find in such cases. You were talking about coagulation defects, factor 5, lydin, factor 2, prothrombin, and this is all the methods which are there. Sir, would you talk on this about hyperhomocystinemia?
Yeah, I mean, again, that is also blamed for this,
Okay.
but finally the treatment option is the issue.
Thank you so much, Dr. Subhash Malya. We go to your case 3. You can go on reading. Thank you so much, both of you, and the comments which were there. And I'm thanking all of you. Thank you.
Yeah, at the outset, let me thank Niranjan sir for this wonderful opportunity. It's a 20-year-old female presented with pain in the lower abdomen and right side of the pelvis, especially during her periods. And her periods were early and profuse with severe pain in the lower abdomen, which goes to the back. And there's a feeling of excessive heaviness in the uterine region. And the patient has had 3 abortions between 3 and 6 months in pregnancy. So the question probably would be, what next in this case? And sir, may I have the ultrasound findings? Yeah. The ultrasound shows a posterior wall fibroid 4 into 6 into 5 centimeters in dimension. Now, based on since the time is less, I think we'll go directly. The ultrasound finding has shown it's a posterior wall fibroid. What exactly I would like to know from this particular ultrasound is whether there is any cavity has been reached, or whether there is a submucosal component to it, or whether it's purely a subserosal fibroid. Because this is what it will matter. Because if it's a subserosal fibroid, usually in cases of this, in subserosal fibroid, we usually don't take much of an importance because they usually are known to be naive. Of course, if it's an intramural one with more than 4 centimeters, and with this case where we've had 3 or 4 abortions, 3 abortions, probably there is a role in doing a myomectomy in this case. Though the evidence, either the ESHRE guidance or even the IN guidelines or even the ACCEPT guidelines, they do not give any particular suggestive of supporting this. Of course, if it's an intramural one, I mean, if it's a submucosal one, I think there is no doubt we will have to go ahead and remove the fibroid.
So I agree with you, sir, that it's not just because you are an endoscopist. I'm an endoscopist, and we put a scope and remove the fibroid, right?
Sir.
Yes.
No, definitely not, sir. No, we are as you have rightly put it across. We are not. I'm not here to suggest that no, every fibroid is to be removed. No, that will be very, very clear.
So we will do one hysteroscopy, sir, in this case. Subhash sir, Malya ji,
sir.
We will do a hysteroscopy also.
Absolutely, sir. Absolutely, sir. Because many a times when we have had in patients who have had a IVF or even in pregnancy, they would not find a cause. When you do a hysteroscopy, usually we find something or the other, like a septum or a polyp.
It is missed out in the sonography, and it's always better to believe you can do office hysteroscopy. Sandeep, you raised your hand.
Yes, sir. This point of hysteroscopy is very important before any myomectomy, because rarely you will find sometimes some adhesion band or septum associated with fibroid. So if those kind of things are there, that could be the real reason for your repeated pregnancy loss. So hysteroscopy is a must, and if you find something, you can correct it then and there.
Yeah, but the possible mechanisms of in this could be a small cavity, it could be a lesser suitable area of implantation, a vascular compromise, or it could be even a mechanical constraints of space. Now, these are the reasons why it is hypothesized that it could be the case cause for the RPL. Yeah, Shajish, please, sir.
Yes, please.
Yeah. The other point, other than cavity distortion in a lady who's having a recurrent pregnancy loss, would be the abnormal contractility, which has been shown by certain studies, especially the video MRI studies and all that have come out. A lot of them have come out from China and Korea and all that. There are some good evidence which tells that there is a issue of abnormal contractility, which probably can be tackled when you don't have any other causes found out for a recurrent pregnancy loss. Thank you, sir.
I think it's a very important point, and I want to tell you to hear all of you and see Kiranmay, Saijus, Niranjan Chavan, Subhash, Murlidhar, Sandeep Dattarai. We have crossed 1650 users. They are live. There are questions being asked, and the same approach what has been told now was discussed. And they're online, they're all the time asking questions, they just go on and on. But we are so nice and we are so good and we complete the whole picture. But in such circumstances, you're given all the things treated with immunoglobulins, low molecular weight heparin, done hysteroscopy. There is nothing there. Maybe Sandeep would see some bands here and there. We cut it, juice, and then we put there on progesterone, and then we put also a Foley's catheter. Everything done. We prime. But sometimes it happens that in spite of all these things, things don't work, things don't work. Sometimes that posterior wall fibroid is somewhere near the cornu, it is there nearby. So it's always better to put a scope. We do not want, or we don't want to say that we do a laparoscopy here, but surely in that opportunity, if we get, then I'm sure Subhash, you can just tell us briefly, if suppose we put a scope inside and we go in, what do? You find a fibroid there. You already taken a consent, done everything.
Sir,
You have treated her.
in this particular
treated
case,
her with IV IgG, which is not affording probably, or she has taken all the treatment, and then still we have that fibroid. Then why not remove it? What's
yes,
wrong?
sir. The recommendation would be that evidence for removing fibroids may be uncertain. But in this case, or in many other cases, when you had a repeated loss and you're not able to find any positive finding, any finding is a positive finding. You had 3 losses, you had a big fibroid, definitely I will go ahead and do it. Yes, I do accept that the recommendations may not be there, but I think it is seen that when you have such a big fibroid and you had a repeated loss, you do a myomectomy. Definitely that is going to help you out. And what the studies have also suggested is when you have in such cases, the pregnancy rate or the live birth rates are much better when you do a myomectomy, though it may not be statistically significant. But I think every baby that you're able to give to the patient, I think that is what at the end of the day matters.
So you're done the patency, you go ahead, you're doing a myomectomy. Dr. Subhash Malya, the endoscopic chairperson, live.
Sir, yes, as you have rightly put it across, sir, we will definitely be injecting vasopressin as you have used a VVIN needle which has been used here. Okay, this is actually by our colleague from Mumbai. And as sir has put, posteriorly one, so sir is also preferring the transverse incision because the suturing will be much easier. As sir has rightly put it, has done it. Yes, put a transverse incision and with an harmonic, you just cut out you just remove the capsule. Now, once you get into the capsule, I think as sir has demonstrated, it is very easy to nucleate. It just pops out. It definitely just pops out. You can use a myoma screw for the enucleation part of it, and then you just remove it. One word of caution is in this case definitely not, in case if you have removed or opened the cavity, you will have to suture the cavity. Be very careful about that and do write it in notes, because if you have done a cavity distortion or cavity removal, these are not the ideal candidates for a normal vaginal delivery later on. So for these reasons, if you find that the cavity is removed, please do write it across, and so that it can be for an elective CS. Now in this case, definitely yes, since she's had a 3 loss and you've removed the fibroid, I'm sure, I'm optimistic that the next pregnancy will definitely be a term pregnancy with a very good live birth. Now again, suturing part, sir, you have here using the barb sutures. It's a wonderful suture, and the best part about barb is it just stays in place. It makes your life much easier. And as sir has done it, you do the baseball technique, inside out technique and outside in technique, so that you don't expose the sutures outside. One thing which I would like to suggest is when you do a suturing part for all, I'm sure many of them would know, the principle is approximation and not tightening. It is not to really tighten it and damage the vascular supply. You just approximate it on both the sides so that there is a good healing. Your aim is to reduce the dead space and the bleeding, and this is what we have done, sir.
Can you hear the music? No. Only I can hear the music and I'm enjoying the music. And that's how we morcellate. We can do endobag morcellation.
Yeah, definitely, sir. Definitely, either endobag or a colpotomy or just because this fibroid looks very innocuous. So I will not go into the controversy of bag and other, but this looks very innocuous. And as you have done, I would also do the same thing. Now coming down to this, the interseed, the interseed which sir is using, definitely yes. If the patient is affordable, if you really want to avoid any adhesions, definitely yes, interseed is a good option. But only thing I will suggest to all the viewers is when you use an interseed, make sure the hemostasis is achieved. If there is a blood, it doesn't help out much. Yes, sir.
So that was a wonderful presentation by my unit members, and Dr. Subhash Malya gave a wonderful commentary on the whole video of laparoscopic myomectomy. Claps for him. Amazing.
Sir,
And I think you have
my,
covered
my,
all the
my,
points.
my livelihood, sir. My livelihood. Sir.
So that was amazing. That was so great. Those barb sutures which were there, and the way the technique of putting, and then we had interseed, and we can do endobag morcellation also. Please keep that in mind. And I'm sure, and she conceived after the whole treatment and being given her the pampering, and she conceived. She has a child now. Things have changed. So
Yeah, as sir has rightly put it across, in cases of RPL or any other pregnancy, such things, I think any finding is a positive finding. If you find any finding, in such cases, I think that is we should take it as a positive finding, and I think we may be justified in those. This is my view, sir. I can be wrong, sir.
No, you're not wrong. How can you be wrong? You're a responsible endoscopist. Very nicely done. Very nicely talked. Thank you. Dr. Saijush is raising all the time hand.
Just wanted to add on that this goes on to prove that in RPL, the value of a baby is much more important than the P value.
Very
That's very important.
Thank you. Thank you. So, Doctor,
always we have to individualize the patients.
Yes,
there's absolutely no doubt in that.
Absolutely. Thank you, sir, for your expert comments. Dr. Sandeep Dattaroy, you can read the next slide. Please.
Okay, first of all, I would like to thank Niranjan sir for this opportunity. So here we have a case of a 28-year-old woman married since 6 years, approached to a fertility clinic for secondary infertility for 4 years, and she had 4 abortions in the past. So this is a typical case of a recurrent abortion, how it presents. And she attended a health screening about a year ago and had an ultrasound pelvis done. So this is most of the time, this is the first investigation they will do, which showed a septal uterus. So this is the typical way a patient with septal uterus will present to us. 4 or 5 abortions, and then they will go and will initiate the investigation. So initial investigation is always a transvaginal ultrasound, and most of these cases we can diagnose with transvaginal ultrasound. Some of this patient will come to us with an already diagnosed case of septal uterus with hysterosalpingogram or some other investigations. Sometimes you will need a little higher investigations like 3D ultrasound, or sometimes even MRI if you suspect some complex congenital anomalies. So all these investigations are done to rule out any other abnormalities. So the treatment here, this patient underwent a uterine septum resection with concomitant laparoscopy. So there is sometimes
before you go to the point number 3,
yes,
I want you to describe such patient which comes with a uterine septum resection. You have done an office hysteroscopy, or you have taken under anesthesia her, taken a consent. Please tell us, how would you proceed?
Yes, nowadays, like some of these cases can be managed with office hysteroscopy, but most of these patients we prefer to do in our routine operating theater. Because we always, like most of the cases, we try to do a laparoscopy, especially when they have associated infertility. Most of these patients, you will find that they have 3-4 losses and unable to conceive. So with this kind of history, when they come, so it is always better to do a concomitant laparoscopy also, so that we can find out the tubal factors, we can rule out any minimal endometriosis, etc. if it is there, so that also we can tackle at the same time. And if you do it under laparoscopy, if there is a small perforation, you can always tackle that thing. You can rule out any bowel injury, or if you want to put a suture, like if a patient wants to become pregnant in future, so even if it is a small perforation, we always prefer to put a suture. So laparoscopy has all those benefits. But if it is a very small septum, that can be managed even without a laparoscopy. So, but personally, I always prefer to do a laparoscopy in the theater. So that is what yes.
Absolutely, Dr. Subhash Malya, I want to see you live. Please don't show your photograph, passport size. Please come live. Dr. Subhash, there are questions for you. Dr. Subhash, there is a question from Nepal. Dr. Shrestha, she is my fan. She always is there with us, and she asks a lot of questions. So this question can be answered by anyone. All of you are the great endoscopist here. We were talking about the cavity, and Subhash said that when the cavity is open, or it usually doesn't open, but if it opens.
Can I make a point in that?
Yes, Dr. Reena Shrestha from Nepal. Dr. Reena Shrestha, she's from Nepal. We are pan India. If the cavity is opened, indication for cesarean section. Is it an indication for cesarean section?
Sir, can I make a point?
Yes.
See, when the cavity is opened, we usually follow the principle of closure, like how you're doing cesarean section. So it is not necessary that you always have to take a bite through the endometrial cavity, because endometrium you cannot separately close. It is a very thin, it is a very like jelly-like structure. So our principle is you just go at the endomyometrial junction, take out your suture through that, and then again go through the endomyometrial junction and come out to the myometrium. So we usually, when it is open, you have to do it in 2 or 3 layer suturing. So it is not necessary that you have to go through the cavity. So endometrium, whether you include or not, it doesn't matter. You have to do it exactly as you do in your cesarean section. So that should be the principle. And for us, like we have around 40 deliveries after cesarean, after lap myomectomy in last 8 years. So we didn't have any cases of dehiscence or rupture or anything. And all these patients delivered by cesarean except one, she had a normal vaginal delivery. So suturing, like there should not be any confusion that you open the cavity, you have to suture endometrium separately, nothing like that. Controversy is gone now. So you have to go through the endometrium, just like cesarean section, you close it. That is the thing.
Okay.
And always do a multi-layer closure, 2 layers or 3 layers closures.
Very good, very good. The same question has been asked by Dr. Krita, Dr. CHRTHA. I hope I'm spelling it right. Preferred mode of delivery with a big posterior fibroid. Well, she can deliver vaginally. That's not an issue. She's been also asking the same question, and I think that's great. Wonderful. Sandeep.
Yes, sir. So, sir,
we continue with your septum resection. Dr. Subhash Malya has arrived now after the question has been answered.
No, sir. Sorry, sir. I had an emergency call from the hospital, sir. Sorry.
Yeah. No, we just answered that question regarding the opening of the endometrial cavity, and in such cases of myomectomy, what is the preferred mode of delivery, and if it opens. So I think we just answered that. Dr. Sandeep has given the answer well. How will you manage this case? Sandeep Dattaroy, we continue with you.
Yes, sir. So this case, like as you have already mentioned, we have to go for a hysteroscopic septal resection with laparoscopy. And second thing that you have mentioned is laparoscopy, intrauterine contraceptive device was inserted after the procedure. So this is also a very controversial topic. Like many a times people put a copper T after removing the copper. But what we have found in our last year, so 8 to 9 years of experience, is that we don't need to put anything, because if you put a copper T, the surface that it separates the copper T between the walls, it is very insignificant. So if you have a very big area of endometrium that has been separated, you can put a Foley's catheter, number 8 pediatric Foley's catheter. You put 3 to 4 ml of saline and then you remove it after 3 days. And on the day of next day of surgery, we start giving 6 to 8 milligram of estradiol valerate tablets. And that's how we have managed. Like we never put any intrauterine contraceptive devices. Earlier, that Lipis loop was available, which had a bigger surface area, but nowadays it is not available. So I personally, I don't use. The last 8 to 8 years of my practice, I have never used any.
So that is your view. We appreciate, but there are people, there are studies which have been said. IUD can be used. A pediatric Foley's catheter can be used.
Yes.
And even they might not use anything, probably.
Yes, sir. So it doesn't matter whether you use or not. So we don't prefer using anything. So that is.
So let us be scientific, sir. Let us be scientific.
Yes.
I don't want your personal opinions. What we require is statistics. We require evidence based.
If you go through the biggest review of septal resection, which is there in fertility and sterility, where they have had nearly 1,000 cases, meta-analysis of 1,000 cases. So there the conclusion is that whether you use or whether you don't use, it doesn't matter. So like it is like that is the reason probably we don't use. But if anybody wants to use, they can always use whatever they want.
So nice of you. You are so generous. Thank you. So
now what you what you said, it is correct. The evidence, what the evidence said, we should always speak about the evidence.
So Ganpati Bappa Moria.
Moria, sir.
Moria.
Ganpati Bappa is still there with us, and we will be having the Aarti in the evening. But before that, he has blessed all of us. We are all lucky people. All are very blessed today. We have got the Rajnikant of South India. I can say he is a film star. And the count has increased to 1700. When I land up with the case number 5, Dr. Shaijus, the count has gone to 1700. And I'm not joking. I'm very, very serious. Yes, because they all love you. They want to see you. Because we are number one. We are number one always. Because we are made that way. We want to get the best of it. And we want the best professors here with us. And it's such a great thing that seniors are telling us, people are telling us, we want seniors, we want seniors. They're bored sometimes. I was also a young man, but still, when they are blessed to see Dr. Piley, Dr. P.K. Sekran sir, Dr. Pratap Kumar, and the doyens which are there with us, guiding us, it's amazing. People want to hear seniors, and that's why we thank them from the bottom of the heart that they have been here today with us. Dr. Saijush, please go ahead.
Yes, sir. It's case number 5. A married female, aged 31, attended the gynecology with complaints of menstrual irregularities since 15 years. She's married for 12 years and has some routine laboratory investigations which has come normal. She unfortunately has a history of 4 2-month duration by spontaneous abortions. Next slide, sir. Yeah. As a workup, there was a diagnostic hysterolaparoscopy which was done and showed a uterine cavity of length 3.5 centimeters with irregular multiple additions which are firmly dense, and it was, as expected, suggestive of Asherman syndrome. The fundus and bilateral ostia as well as the 2 cornua were not visualized properly because of additions.
Yes. So please tell us now. Yes, we got Asherman syndrome, sir.
Yeah, probably this is one case where I would doubly call Ganapati Bappa Moria before I enter, because Asherman syndrome still remains a challenge even in the best of hands who do hysterolaparoscopy. Now, certain cases might not be as difficult as we expect when we enter, because the additions are very flimsy and they are localized to a particular zone. Maybe only some isthmic additions or additions which involve only a part of the cornua. Those cases, without just instilling the distending medium into the uterine cavity itself, may break these flimsy additions, and that might be all that you have to do to restore a normal.
Hydrodissection, are you talking about hydrotherapy or something which you want to quote?
Not exactly termed that way, sir, because anyway we will be using a uterine distension medium for all operative.
So what is the distension medium, sir, for the operative purpose you will be using? Please specify.
Yes, sir. Most likely, I am planning to go ahead with the cold knife dissection, most likely, because that, in comparison to use of a electrocautery, has shown to have better results in a case of Asherman syndrome. So I would be using a routine electrolyte solution, which is a normal saline or a ring lactate itself. So distending the cavity itself can break a lot of flimsy additions.
Yes, I agree.
But then the worst case scenario are the dense additions, especially the ones which involve the entire uterine cavity, where the cavity is almost agglutinated to each other. That's when the most difficulty comes. Now, most important care that we need to give is to take care at the time of entry itself. Because even identifying the internal loss and progressing from there, even that initial part might be very difficult. So people, even I use misoprostol doses before I prepare this patient for a hysteroscopy, so that there is some amount of cervical dilatation, which allows the earlier part of the procedure. Once we reach the internal loss, it has to be a very, very systematic way of doing it. Generally, as is always said in literature, we start from the center. We start from the areas where there is least amount of additions and then go to the more difficult areas. That tendency and that pattern is generally followed, because if you go to an easier area first, it will allow a little bit more of distending medium to enter the uterine cavity. That can help the breakage of a few more additions. Now, generally we in a septum we follow a central approach, but in dense adhesions, we have to attempt to cut it off from its junction from the endometrium. So slowly make yourself some space and move ahead. Before that, most importantly is the counseling that you will give to this patient before taking up for a hysteroscopic procedure. You will have to counsel her regarding the requirement of multiple sittings. That means you might not be able to finish this adhesive lysis in one sitting. So you might have to go step by step to ensure that the volume overload or electrolyte disturbances that are related to an operative hysteroscopy doesn't cause morbidity in her. Number two, the requirement of a second look hysteroscopy may be required in this patient. Number three are also the risk of complications, including a perforation. Though many a times we do not tend to tell people this. Ashramant is one case where it is good to be honest and tell her that these are possibilities and what all precautions you are taking to avoid these kind of problems.
Absolutely. I request Dr. Pratap Kumar sir to please come online. Dr. VP Piley sir to please come online and share your thoughts. I want your opinion and your experience which you have shared for the last 35-40 years of RPL, and that's why we want to hear seniors. I request Dr. Pratap Kumar and VP Piley sir to please come online. Thank you.
Thank you, Niranjan. I think I must congratulate you for your excellent questions, and the panelists have done extremely well. And I was listening to every bit of it. And then, what I find is most of the time when you investigate, you really don't find the, whether it's chromosome or the uterine or whether it is blood test, we don't find the cause at all. We still, a lot of advances have yet to go forward to understand the intricacies of that. But one thing is for sure, you find the conceptus chromosome conceptus is abnormal in the product chromosome enamel chromosome is bad, then it doesn't recur. That's what you should know. If the chromosomes are normal, then they come under the recurrent pregnancy list. I think that we should know that point. Because a single abnormal conceptus is an evidence of one abortion. It doesn't mean, so I always tell my people, if the products are showing chromosome abnormalities, very good. That means it won't happen again. Recurrent aborters will have a normal chromosomes, apart from what panelists. And one more thing is, though I know it is the immunological factors are not very much really the proved fact, but there is a role. But I think over the years we will do more about immunological rejection factors and then come into kind of decision taking. And one more thing about uterine septum, it doesn't mean that all uterine septum must be removed. A small septum, just leave it alone. Again, randomized controlled trials have said that a small septum need not be removed. And fibroids, once again, a serous fibroid need not be removed unless, as Subhash Malya has said, if it's disturbing the cavity, if it's more than 7 centimeters, I think we should remove. Otherwise, you're going to make an unnecessary scar on the uterus and again have a problem. And one last thing is, and these recurrent pregnancy losses, though we are talking about first trimester losses at the moment, if you really look into the future of these pregnancy losses, supposing there were 3 or 4 abortions the first trimester, and sometimes everything goes on beyond 12 weeks, but you'll find she suddenly aborts by 16 to 18 weeks. I think the connectivity to the second trimester losses, though actually there was no insufficiency before, but the repeated dilatation of the cervix also can cause a little bit later abortions and sometimes preterm labor. I think otherwise you have really covered very well. That's what I want to tell. Correct. Thank you so much.
Thank you, sir. I would have taken you earlier. I was expecting, I apologize to keep you for a long time waiting. But surely, sir, you could have just come inside and given your expert comments. Thank you for being there, sir, and spending your valuable time. Dr. VP Piley, sir, please, your comments. I wanted actually to finish all the cases so that you get an overview of the idea, and then generously you have guided us that yes, Pratap Kumar sir, you have guided us that it's not always that you have to put in a scope, not always that you have to cut the septum, and not always that you require all those things. So you have to be very sure of what, that is what experience speaks. Thank you so much, sir. Dr. Piley sir, please continue. I'm sorry to interrupt you.
No, thank you very much. Thank you, Niranjan. Am I audible?
Yes, sir. Yes, sir. You are fantastic.
Okay. Yeah. Thank you. Congratulations for covering such a wide variety of topics, and that too of relevance, and especially for covering the chromosomal aspects. Chimanbai and Muralidhar have covered very simple terms and carried the messages very well. Congratulations on that, because these are areas which usually are beyond the ordinary practitioner. But one thing I agree with Pradap, that we also don't see, even though people say about 2 or 5% of all the recurrent pregnancy loss, you will see a chromosomal abnormality. In reality, we don't find that many in the parental chromosome analysis. Now, again, Muralidhar has highlighted the importance of not depending too much on TOG and why it should not be a part of the investigation panel that we take. Uterine anomalies, I agree with Sinta that a septum resection, I feel, Niranjan, even though you seem to think that IUCD may be recommended, but I feel that maybe people will overdo it, and I also don't put IUCD after that. Regarding the cervical insufficiency, which may be the point that you did not want to cover, but
no, we are covering. We have got the highlight, the main person, Dr. Kiran Mai. We have got till one case.
Yeah,
Yes, sir.
we are waiting for that. It's
Yes,
okay.
yes.
Yeah. So probably of all the things where we can do something very effective, I would have thought is the cervical cerclage. But I don't know what Kiran Mai is going to say. But one message I always communicate is, if you take a real patient with cervical insufficiency, the cerclage should be done properly, and just a McDonald is an eye wash. You should have a proper cerclage at the level of the internal os, which means the Shirodkar. And the cervix is deficient, you should put it at a higher level, and that is an intraperitoneal or ischial cerclage, which can very well be done vaginally. That's all what I wanted to convey. Thank you very much.
Dr. Murli, sir.
Yeah, with due respect to both my senior teachers, Dr. Pratap Kumar sir and Dr. Paili sir, actually what I was thinking of the same thing, that most of the time chromosomal karyotyping is normal. Then I read into it, I discovered, suppose you do a usual karyotyping, it will come normal only. It will not pick up the translocations, inversions, and other deletion problems. So you have to go for microarray. When you go for microarray, it will pick up. Not that we are able to going to treat it, but at least we know that these patients, instead of again and again trying with usual treatments, probably these are the patients who are the ones, very small percentage maybe, they are the ones who require donor egg probably. So microarray is very important. If you do usual karyotyping, it will come as normal.
And so one small point I would like to make here, sir. I mean, microarray definitely is one thing which will add to the diagnostic capacity. But when we are doing chromosomes of parents, we are doing peripheral blood karyotyping. Many of them are carriers of gonadal mosaicisms, where the chromosomes at the level of their gonads may be abnormal. And therefore, the incidence quoted in literature is different from the incidence that we see during our clinical practice, because we do mostly peripheral blood karyotyping.
Chinmay, are you suggesting that if you do the gonadal chromosomes of this, there may be more abnormalities?
There may be a higher incidence of abnormalities as carriers in the parents.
Maybe possible. And to Muralidhar, what I would suggest is, we have been reading in the literature that there will be about 2 to 5% abnormalities, and that was not about microarray. That was about the numerical analysis that literature says, but we don't see it that many. That's what I said. Of course, if microarray comes, we may pick up abnormalities which we were not finding out hitherto. But what people and the literature had been saying was numerical anomalies or structural anomalies, which were not seen when we tried in practice. That's all what I wanted to say.
Correct. Numerical abnormalities will not be seen by karyotyping.
I also want to add on, you have to actually, instead of just the numerical chromosomes, if somebody suggested, like Muralidhar Pai said, balance or unbalanced, I think Kiran Mai also spoke about it. That is more important than just, when the structural anomalies are normal. If somebody can tell us balanced or unbalanced, that will make a lot of difference.
Yeah, that would be easier by microarrays.
Yeah.
Yes, it is a wonderful thoughts been exchanged by all our seniors. Dr. P.K. Shekaran.
Very fortunate and blessed today, sir.
Yes.
To have you all. Yes.
Dr.
And with such a
Lively
moderator.
Yeah. I lost my connection in between. I was listening to very carefully about all the presentations, especially regarding the uterine anomalies. I mean, the fibroid and the discussions was very good. I was also wondering from the textbooks, we used to be told that you have to close the endometrium. I was wondering, it is not the endometrium that is holding the uterine incision or the wound. It is the muscle which has to be approximated properly. So that point was discussed further on. That was good. Then about the chromosome anomalies, for just one abortion we will not do, but recurrent abortions will have a place to check for the chromosome anomalies. And luckily, some of the chromosome anomalies will not recur. That is what it is. Then about the other infective causes, it was very well discussed, and no place for torch and other things were stressed, because nowadays people don't think of it nowadays. So it is nice to see that we have left it, torch or the torch. And then coming to the immunological therapy, we know that the place is not there. But if the patient is rarely NA positive, there is a place for corticosteroid. We had 2-3 pregnancies going to term with the corticosteroid and other support. So there is a limited place though. So these are some of the highlights that I could gather from today's so far presentation. Very nicely done, Niranjan. Carry on.
Wonderful, wonderful. I am thanking you, all three seniors. The count was 1650, and after you have come, 122 number has increased, so it is 1772. And this is the amazing, the magic of seniors. The nation wants to hear you all and your comments.
Thank you.
Yes, what a brilliance of a discussion. The subject is so old, spoken out. We suddenly had so much angles and twists, and that's what happens when true science is spoken by the young and our younger, senior together. It's amazing. Thank you.
The Republic TV might be losing some of its viewers now.
No, sir, it's all because of Ganpati Bappa Moria.
Yes, thank you.
Before you proceed, I just want to tell one word, one sentence. Torch has lost its light. Just remember that.
Correct.
Yes.
Torch has lost its light. All the people have listened to know that.
That's very beautifully put it, sir.
Torch has lost its light.
So, madam,
yes,
answers. The light is still here. The light is still bright, and we can see that from Hyderabad. Dr. Kiranmai Devaneni.
Yes, sir. With your permission,
you can just briefly tell, and then we will just finish in few minutes.
Yes. A little bit about my name, sir. It is Kiranmai, not Mai, sir, as mother. That's how my parents name. But you made it, unforgettable for me. Thank you. So with all the seniors' inputs which are readily available, and we are so fortunate to have luminaries in the subject and all of them together, I'll just go ahead and just give my inputs and leave it to seniors to cover in more detail. So this is Mrs. XYZ, 35-year-old. History is repeated second trimester losses or preterm births with painless cervical dilatation and prostate labor, very typical of history which is indicative of cervical incompetence. And then ultrasound, is it the cervical length is less than 15 mm, sir, finding?
Yes.
Or okay, I mean this history is typical of cervical incompetence. Then I think you want me to say the various types of cerclage. One is history related, and the second is ultrasound indicated. Third is examination indicated. This is a new terminology rather than the previous elective, urgent, and emergent. So history is if you go according to the evidence, it is 3 losses which are suggestive of mid-trimester or preterm births. Whereas ultrasound, it is less than 25 mm till 24 weeks. When we do a serial ultrasound, either without any symptoms or when there is a history of 1 or 2 losses, when we are following them up with serial ultrasounds, or in case of a precious pregnancy or ART pregnancy. Then examination, when we examine the patient by perspeculum examination, when there is a shortening of the cervix, internal os opening is there, that is examination related. So when there is history indicated cerclage, it is generally done in early pregnancy, around from 12 to 14 weeks, because we already know that this is typical history, whereas ultrasound indicated is a little later, because as we are checking on the ultrasound, on serial ultrasound, when the cervix length is less than 25 mm, then we go for it. Whereas emergency examination indicated is little later in an emergency situation, which requires a lot of skill and experience. So this is what you have already very clearly here put it as history indicated, prophylactic ultrasound, and then rescue or physical examination. Urgent is combined. Okay. Then
what is the role of proteomics? This is something which goes to. You want to take this question, or we will go to the progesterones? What is the role of progesterone?
Yes, progesterone is a wonderful hormone. When we see its interplay at the cellular level, how it modifies the immunological and then the receptor level thing at the immunomodulator role, which it has in coercing the pregnancy or making the uterus quiescent. And the role of it becomes very clear when we see the role of RU486 as an antiprogesterone, which disrupts the pregnancy in early stages. Then the immunomodulator action, progesterone, we can say three main important roles. One is it makes the T helper cell system to go towards one type. There are two types, 1 and 2. Makes it go towards the one type, which stabilizes the pregnancy and immunomodulates. And then the presence of progesterone makes the factor of that is progesterone PIBF, which helps in stabilizing, again, anti-inflammatory immunomodulatory role. And then again, natural killer cells. It has a role in decreasing the natural killer cells, which again reduces the apoptosis and, the destruction of the natural killer cells releases a lot of substances, and it has a role in pregnancy loss. So PIBF, this is what I was telling, the TH2 cytokines, which favors towards the TH2. So definitely there is a great theoretical role, and we also see even in cerclage also, whether we go for cerclage or whether we don't go for cerclage, when there is no definite clear history indicated cerclage, when there is a history of only 1 or 2 mid-trimester pregnancy losses, definitely we are going to put her on progesterone. So for its theoretical advantages, many times it does help. So this is about progesterone. Yes, but again, as we say in luteal phase deficiencies, how to document the progesterone deficiency, what are the levels and all, it is very difficult. But definitely it has a role in immunomodulating role, and it has a role in maintaining the pregnancy. I request Paili sir to add on cerclage.
Yes, seniors, please comment. There is something like spectrum theory.
Yes, just reading it. Prevention of embryonic
coming to the cerclage part, I'm not a fan of if there is a historical as well as observational confirmation that there is cervical insufficiency. I feel that there's a definite role for cerclage. But as I just indicated earlier, cerclage, if it is to be a benefit, it has to be at the level of the internal os. Anything below that may hold the pregnancy for a little while. For example, an exposed membrane may be hidden by cervix brought in front, but a real cervical insufficiency will be taken care of only if you are able to tighten the internal os, not below that. You can even go above that, because sometimes there may be deficiency as due to previous cervical tear or amputation or other problems. Then you may have to even go higher. The principle is where you put a cerclage, below that level there is sufficient length of the cervix to hold the stitch in position. That's all the principle. We use very little progesterone for these cases because I don't know. It's all about the stabilization, this and that. I think lot of education, but I'm not a fan of using a lot of progesterone for such patients. In fact, little, I would say. But regarding the patients with cerclage in a recurrent pregnancy loss, sometimes you may end up with situations where you may have to do with an open os already, in which case there is a role for emergency or a rescue cerclage also. That's what I would suggest, where even if the service is open, we can get that service to get that membrane go back after putting tocolysis. Previously, years ago, we used to depend on the halothane as a general anesthetic agent, but of late, we can use GTN drip to get the uterine myometrium relaxed, and under spinal anesthesia, we can get bulging membranes go back. And to get that membrane pushed back, I hope some of you at least would have seen the technique that we have developed of using a Foley catheter, distended Foley catheter with a sound inserted so that it becomes stiff, and then push the membrane back, give good deep Trendelenburg, and then get the cerclage at a level whenever possible as a Shirodkar. But in an emergency cerclage situation like that, it may not be possible to dissect the bladder up and put it at a high level. But of late, even in such situations, that is what we do, because unless you put the cerclage at the high level, results may not be correct. So to summarize, my point is, history may be the best clue to a suspicion of an insufficiency, but if you see serial measurements, that will be the second point that helps you to make a diagnosis. You are not to give up. Even if you see a cervix which is open, you can push the cervix, the membrane back, and put a cerclage and continue the pregnancy higher. So in the cases of real insufficiency, there's always a role for properly done cerclage. That's all I want to say. Thank you.
Can I just add on, sir? Can I just add on? I think I agree with Dr. Patti. I've had few cases where McDonald stitch has been put twice and then they're still aborted. Those cases, I have done Shirodkas and Cerclage and they have really worked very well. I think we have to train the juniors to do Shirodkas and Cerclage, sir, because many people have not even seen one.
And sir, what is your opinion on abdominal cerclages for the failed vaginal cerclage?
I am not doing abdominal cerclage because we have been doing very good Shirodkas and Cerclage, I should say, and they've all done pretty well. I think the cervix is very short, probably you think about abdominal, but I have no experience in that. Maybe the others can answer.
Chivanmai, if I may comment on that, we have gone through all this. Abdominal cerclage, laparoscopy cerclage, and finally, after a paper came from France, we have resorted to transvaginal intraperitoneal cerclage. Those of you who are used to doing non-hysterectomy can very easily get the bladder lifted up and enter the pouch of Douglas and put the cerclage above the level of the uterosacrals with a knot put intraperitoneally, close the vaginal opening and then come out. That will put the stitch at the same level or even above the level that you get by abdominal cerclage. So we have stopped doing abdominal cerclage or laparoscopy cerclage. We do only transvaginal intraperitoneal cerclage. It's a very rare situation where we will think about an abdominal approach, except in patients who have a very deficient cervix, which we cannot even grab from below. In such situations, we may go. But in clinical practice, very seldom only there's a need for it. Thank you.
Thank you. Thank you.
1 second. I think basically if you use a muslin tape for Shirodkas, which is a modification of the old Shirodkas, most of them do pretty well. But as Dr. Pailisa said, the cervix is very short. We are in trouble. I think his technique, we should try intraperitoneal.
Okay. The one point
Shagan wanted to say something.
No, it's okay. Just one point I want to stress is the history, if it is very typical, the mid-trimester abortion or a preterm delivery, don't depend on the cervical measurement at all, because people are at the recurrent abortion happening again because the cervical length measured was more than 3.5. So if the typical history is there, please go ahead with the cervical time. That is one request, because sometimes the cervical measurement may be normal. So it is, and with the reintroduction of the stressing of the Shirodkas point is very important at the correct, but where is the deficiency is at the internal loss. So we have to somewhere near that has to put the stitch. Now, Niranjan was showing that contributions of Shirodkat in obstetrics and gynecology. I think it's a wonderful wonderful text which I was possessing, but I can't trace it now, where you won't see the modified Shiroka's technique of prolapse repair nowhere else. Nowhere else I could see other than in this book. So it's a treasure volume that I think we should try to more pick it up and try to edit or print it again and get it circulated. It's a wonderful monogram by Shiroka. It's a wonderful book where all these procedures are there. Some of them, of course, has become unnecessary because of the implantation, uterine implantation on the cornu and other things may not be required, but other things are very relevant, and the history where he has gone to Manchester and proved that what you are doing is you cannot do the correction of the prolapse and then when the service is looking at you, you are amputating the portion which you cannot push it up or bring it up, brace it up. So that is where he has gone for the extended Manchester, where he has used the uterosacral ligament, and the descent of service from the spine to coming outside is at least 5 centimeter, and what you are shortening by McEnroe's shortening is only about 2 centimeter. So you are not doing a corrective surgery, and then what you cannot do, you are amputating. The cervix is looking at you, or it is still outside the vulva, so you are just amputating, with the problem for the young lady to conceive and deliver again. So it is a wonderful monogram where all those things were described. And thank you, Niranjan, for showing that book. Pailu sir has re-emphasized that you have to put the stitch at the level of the internals, where is the defect is at that stage, at that level. So thank you, sir, for again re-emphasizing Shiroka's point. Yes, sir.
Thank you, sir. Dr. Pratap and Dr. Paili sir, Sekaran sir, the nation wants to know the seniors and the younger generation. And it's amazing. I'm blessed today by Lord Ganesha. And I would like, Dr. Sandeep, you raised your hand.
Yes, sir. I have a question, sir, to Paili sir and Pratap sir and seniors. Last 6 months, I had 2 patients, primary patients, without any history of any surgery. One had abortion at 18 weeks, painless cervical dilatation, and she aborted. Then another patient had 24 to 25 weeks, she had abortion. Both were primary, no predisposing factors, and first trimester cervical length was around 3.5 to 4 centimeter in those patients. So, how should we go about managing this patient? Should we go for an interval surplus now, or should we allow them to become pregnant and proceed them?
Yeah, I think the first choice is she should become pregnant later and put a stitch at 13 weeks. As Dr. Sekaran said, don't wait again because cervix is long sometime. At 13 weeks, you must put a stitch, and ideally Shirotkas and Saklas in this case. If possible, at least if you're not been trained, at least do McDonald's. But I think otherwise you can...
I fully agree with Pratap, because the advantage of the first trimester is the advantage that Pratap said, let her get pregnant, do the first trimester scan, make sure it's a normal pregnancy at least until then. But before waiting for the service to get shorter, you put it at the right level.
Yes.
As Shekaran emphasized, people are actually put off by saying that service is 4.5 centimeter long. So what is the need? And that is a that's a wrong impression that we get. We should put cerclage if the history of the first was very typical. The Americans have agreed that even with one typical case, you can take it as a insufficiency. Even though some others say you should wait for 2 or 3. I agree with Sudipto that even after one typical case, without waiting for the serial scans and shortening, I will put a cerclage for such women. The history is very typical.
Thank you, sir.
Great. There are wonderful comments and wonderful praises. I want to take those doctors' name. Dr. Yazini Selvaraj from Madurai. She says, with Dr. Niranjan Chavan as moderator, just like listening to a cricket commentary with high spirits, wonderful webinar.
With great attendance. Harsha Bogle.
Yeah, thank you. Dr. Gopinathan P. Matanor, you may correct it if I am wrong.
Sir is the president of K4G, sir. Just the immediate past president of Kerala Federation.
Oh, Matanor Kannur, Kerala, excellent webinar, expert comments by senior teachers. Dr. Niranjan, you are wonderful. All the panelists were awesome, good. Hats off to you all. It's great. It's going very nice. And we have many questions, but I would love to thank all those doctors, which we have got more than 772 doctors which have registered and are online, in spite of having today a program in Kerala in the morning. And we would like to thank all of you being here in the evening. So this is a standing ovation to all the seniors who have come today, Dr. Shanta Kumari, Dr. Pratap Kumar sir, Sanjeeva Reddy sir, VP Paili sir, PK Shekaran sir. We had 1,772 members today because of you. Because TOG webinar content is always outstanding, it is excellent. And these are all the wonderful comments which people have sent in their own language. Dhanyavad, Khub Chan. What a choice of stalwarts. Back to school effect today. Seeing all the teachers gave goosebumps. So doctors, thank you so much. It was a great pleasure, all of you being there.
Sir, on behalf of all the panelists, we would like to thank Niranjan Chauhan sir and Komal madam for this wonderful, for arranging this wonderful meeting, sir. Thank you very much, sir. Thank you very much, Komal ma'am.
Yeah.
Niranjan, you did extremely well as a moderator. Congratulations. And all the panelists are extremely good.
Thank you, sir. Thank you very much,
Once
sir.
again, thank you for your committee.
Thank you, Pratap sir. Thank you, Paili sir. Thank you, Shekaran sir. Thank you, Kiran madam. Chinmay madam. Muralidhar Pai sir.
Yeah.
And Subbu and team, a big congratulations for
Thank you, everyone.
Integra.
Thank you very much.
Thank you, the young
Yes, thank
stalwarts,
you.
and
Subbu,
best
Session,
wishes to
Thank you
wishes
all
to
of you for
Shailesh
exchanging
and
those
Subhaya.
wonderful
Anuja,
pleasantries. श्री
Team
गणेशाय
on.
नमः। विघ्न हर्ता से प्रार्थना, हम सभी को समृद्धि, विवेक, आरोग्य, चातुर्य, संयम प्रदान करे और इसी के साथ हम जीवन के हर विघ्न से विजय होए और आत्मविश्वास, आत्मनिर्भरता से और धैर्य दे। संघर्षों में डिस्काउंट नहीं मिलता, परंतु उससे लड़ने की क्षमता, आत्मविश्वास, इच्छा, परिश्रम के अनुरूप पर्याप्त सफलता है। With this, I would like to thank all of you. With this prayers, I thank each one of you for spending your valuable time. Ganpati Bappa Moria.
Okay, thank you.
Thank you so much, everyone.
Thank you so much. Thank
Take
you,
care and stay
respected
safe wherever
seniors.
you are.